Okay, we're recording.
Good morning. Can everybody hear me?
Yes.
Okay. I know from experience that if I even lean back, sometimes it's hard to hear even with a microphone, so just wave your hand or shout out or something if you can't hear. Good morning. This hearing of the New Mexico Department of Health will now come to order. I would like to welcome you to the public hearing on the proposed repeal and replacement of the following DOH rules, Emergency Medical System Bureau rules at parts 7.27.2, 7.23.6, 7.27.8, 7.2711, and 7.23.13 NMAC. The foregoing rules relate to licensing of emergency medical services personnel, emergency medical services advanced directives, the cardiac arrest targeted response program, supplemental licensing provisions, and certification of stroke centers. In particular, the department is proposing to repeal the current rules or parts of rules that I just described and replace them with new proposed rules. Pursuant to notice, this matter is being heard on this 26th day of October 2016 in the Harold Runnels building located at 1190 St. Francis Drive, Santa Fe, New Mexico. The time is approximately 9:10 a.m. I am Craig Erickson, and I will be presiding over this hearing today. Assistant General Counsel Chris Woodward will be advising the department in this proceeding, and Kyle Thornton, EMS Bureau Chief. I had program manager in my notes.
That would be Charlie.
He is also present on the podium. This proceeding is being held in accordance with New Mexico Statute 9-7-6E. If any of the member of the audience has not already done so, please sign the attendance sheet located at the back of the auditorium with Benito Gomez. We'll proceed with the hearing as follows. Kyle Thornton, the Bureau Chief for the EMS Bureau, will give a brief introduction regarding the proposed rule amendments. We will then enter the exhibits that have been provided in an exhibit binder into evidence, and then we'll follow that with taking testimony or comments from anyone who would like to offer comments this morning. I'd like to remind those giving testimony or comments today that this hearing is being recorded, and before you speak, please state for the record your full name and who you represent, and you should come forward and hold the handheld mic that's at the podium over here so that we can all hear you. And it is being recorded, and we want your voice to be picked up on the recording device as well, so it's important that you use the microphone. The department in this proceeding is not bound by the formal rules of evidence during these proceedings. However, I may, in my discretion, exclude evidence that is incompetent, irrelevant, immaterial, or unduly repetitious. I also may take notice of judicially cognizable technical or scientific facts within the department's specialized knowledge. So at this point, I'd like to turn the mic over to Kyle Thornton, the EMS Bureau Chief, who will summarize the proposed changes to the rules.
Good morning, everybody. Thank you for coming. I'm always pleased to see folks here to provide testimony if they choose. We love hearing your perspectives on the proposed changes. There are 5 rules that we are looking at changing or proposing changes for, and they begin with 7.27.2, which is what we refer to as the licensing rule. Its full title is Licensing of Emergency Medical Services Personnel. The second rule is 7.27.6. That is the Emergency Medical Services Advanced Directives rule. The third rule that we're looking at this morning is 7.27.8, pardon my phone, which is the Cardiac Arrest Targeted Response Program rule. The fourth rule is 7.27.11, the Supplemental Licensing Provisions rule, which encompasses our scope of practice. And we'll be going through the changes for that. And the fifth rule is 7.27.13, the certification of stroke center. The longest rule is indeed the Licensing of Emergency Medical Services Personnel Rule 7.27.2. It is the first in your packet, and I do have some notes for myself to go through and highlight the changes. The version you have is basically a clean version, so you won't see strike or delete anything like that in the version that you've got, but I will try to point out where those changes are. Is there a version that is strike and delete?
I think, Benito, do we have both clean versions? And
Oh, there is a
versions?
strike and delete?
Okay, so
I grabbed the
everybody
wrong
should
one
have-
and just thought they were both the same file. I apologize. So no, I've got mine, so I'm good. But so very good. Thank you for helping me out with that. And with that, I can start down through the changes, if
Okay.
that's okay.
Yes.
All right. On the strike and delete version, which is obviously the easiest to see the changes, just starting at the very top, there's some nomenclature changes. That's really all that some of those strike and delete things are. There's nothing of substance that changes in the rule. One of the things I wanted to point out is that the term training is being replaced with the term education throughout the rule. And that is, every once in a while you get to reflect some personal feelings about the difference between education and training. I think education is a term that encompasses much more of what our professionals go through rather than being trained like a dog. I recommended that the change go throughout. So you'll see lots of strike and delete for the word training and replaced with the word education. So moving through the rest of, oh my goodness, let me silence that. I apologize. I thought I had done that. Okay. Moving through the rest of page 1, nothing too terribly exciting. Again, mostly just nomenclature, strike and deletes. Page 2, moving through, nothing too exciting. The first thing of substance is on page 4, where we clarified the definition of renewal. That you will see that's double X. We just clarified the definition with some more clear language about due dates and how to avoid higher fees and the application of reinstatement fees. It doesn't really change anything in practice, it just makes it a bit clearer. And then we also added that there is a criminal background screening process that certainly existed. That's more towards the bottom there under C, general licensure C. We added a thing there just clarifying in rule that applicants must complete the criminal history background screening. We already had that in statute, of course, and it was in practice, but we had not had an opportunity to add it to rule. Let's see, page 5, I thought there was something that folks should be aware of, that under F there on page 5, a line was added to make sure that schools know failure to maintain compliance with training standards may result, or education standards, pardon me, may result in the loss of approved program status as determined by the Joint Organization on Education. That's a significant change. It was always possible, but it is now just in rule. Down to page 6, number 11 there at the very top of the page, that is lined out, submit a Bureau approved course registration form. That process is no longer necessary. We don't ask for registration forms from courses around the state at the very beginning anymore. That is just not a process that we do. So we removed that as it is no longer applicable. Let's see here. Down a little bit, we clarified, let's see, what number is that? That is, goodness, it's under what is 12, the new 12D, that says, includes the addition states, which includes both clinical and internship experience. It clarifies what educational programs that are from out of state must do before their folks are allowed to do clinical and internships within the state of New Mexico. And we just wanted to make sure that that was in rule. We have a hard enough time finding clinical and internship experience for our caregivers as it is. And we did not want states coming in, programs from out of state coming in and sucking up that time. All right, down to page 7, letter O. We did change, it's just a single strike and delete, but there under O1, the initial licensing examination time has changed from 9 to 12 months. That is to be more in alignment with the entity we utilize for testing, which is the National Registry. That is their length of time, so we just wanted to have that be the same. There's a couple of other changes there that under number 2, we removed that entire paragraph because that process is no longer applicable. So that is just lined out. All right, that takes us to page 8. Again, this is the longest rule. This will be, I promise the rest will go much better.
And actually, if I could interrupt for just
Sure,
a moment, just
please.
for the record, Mr. Thornton is referring to exhibit number 6 when he talks about page numbers as he's just described.
Thank you. I would not have referred to that as exhibit number 6.
Okay.
Thank you, Mr. Erickson.
Sure.
All right, page number 8. On letter R there, that begins with recognition of out-of-state licensure. This is for emergency incidents, and we clarified, and other short-term and mission-specific situations. We wanted to make sure that folks knew that we could indeed recognize out-of-state licensure in certain situations, but that it would be on a short-term basis only. The rest of that has no major changes there. All right. Where am I? On page 8, we, indeed. Page 8 under general, down towards the bottom under initial licensure, we strengthened some terminology there where it says any person applying for New Mexico licensure from out of state, other programs or with National Registry certification, we change that wording to meet the requirements for licensure instead of shall be considered. Just strengthening some language and just wanted that there. And then, let's see here. At the very bottom of the page, 8CF, 8C1F, where it says, and it goes into the top of page 9, it says provide a valid personal and then parenthetical, i.e. non-service or business address, close parentheses. I thought that might need a grammatical change. Just the wording there appears odd, and that may have been my mistake or someone else's, but I think the word address needs to be outside of the parentheses.
Yeah, I noticed that when I was reading these materials yesterday, and I think I can just, in my report, indicate that should be changed.
A grammatical change. That appears elsewhere throughout the new rule because that is something that was added to each level. And so we would need to do it, and I know we can do it kind of all in one chunk, but I just wanted to mention that. The rest of the changes on page 9 and 10 are basically repeats of previous changes. So I did not highlight anything in particular there. There's the same changes from 9 to 12 months, valid personal address, etc. Those are repeated for each level. There's some grammatical changes, spelling out GED to General Education Diploma on 10, but nothing exciting. Page 11, a new letter J was added that describes the process of surrendering a license. This is not necessarily new verbiage. It is verbiage that was moved from the renewal section to this section just because we felt it had better visibility and provided an opportunity for folks to find this when perhaps they wouldn't be looking for that under renewal if they were looking to surrender. So, so there are folks that do like to surrender their paramedic license and drop down to intermediate, for example, for whatever reason. So we've moved that verbiage and improved the verbiage to this point. Now, under reciprocity, just below that, this is a change that is worthy of note. Individuals holding a certification with the National Registry of EMTs at any level must also be licensed or certified by a state or other recognized jurisdictional authority to be eligible for reciprocity unless otherwise approved by this Bureau. Basically, the idea is that someone coming into the state with a National Registry card is no longer eligible for reciprocity based on that card alone. If they have trained in another state and received National Registry certification, they need to license in that state. Reciprocity is recognition of another license, not of a certification. So we are clarifying that and strengthening that language. Certainly I wanted to point that out. Yes, please. Now you can, do you want comments now or at the end?
Actually, do you have a question or do you have a comment you'd like to make?
I have a question that pertains to this.
Okay. Why don't you go ahead and ask your question then? You probably should come forward to the mic just so we can pick you up. And if you could indicate for the record who you are and who you represent.
Yes, sir. I'm Chen Chenal with the Clovis Fire Department. My
Hey,
question,
let me interrupt you. There's a blue button on there. I'm not sure that's operating.
It did work a while ago.
Chen Chenal,
Yeah,
Clovis Fire
it's-
Department. There we go. Okay, so my question is because
You still need to identify yourself and say who you represent.
Chen Chenal with the Clovis Fire Department.
Okay.
Sorry.
How do you spell your last name?
CHENAULT. With my department being on the eastern side of the state, our last paramedic class actually that we had was through South Plains College in Texas. So with this new rule change being in effect, my guys would have to go through the course, be National Registry certified, apply for a Texas license, pay those fees, and then come into Mexico and pay for our fees as well. Is that correct?
There is an out that does say unless otherwise approved by the Bureau.
Okay.
And the reason that exists is that there are situations that I believe you exhibit a good situation where this should indeed be considered. You have to write a rule that applies as broadly as possible.
Absolutely.
And we have in situations where folks are taking online classes in Massachusetts at a program that is not approved in Massachusetts, and then coming back here and saying that they have finished their paramedic program, they would now like to license based on their national registry. And so we are trying to deal with many situations with a rule, but we do leave ourselves the authority to work with particularly border area programs that we understand might have a very good argument to not have to meet this process.
Excellent. Thank you for the clarification.
Thank you, Mr. Charlotte.
All right. Then also too, you will see, much like the term education and training, we have replaced the word transition exam with the word reciprocity exam. So you'll see that strike and delete multiple times throughout the rest of the rule. Alrighty. Down to page 12. And we added some language there at, let's see, just at the top of the page. It's a strike and delete the old F. It is now a new 3. Just to define seasonal as opposed to temporary. The language there used to be sort of conjoined and a little confusing, that a temporary license could be utilized as a seasonal license. but we wanted to make sure that folks understood that those are really two separate things. So there has been verbiage added to clarify those two things, a temporary license and a seasonal license. Also on page 12, licensure renewal. This begins the biggest overhaul to the renewal process in the state of New Mexico in more than 30 years. It simplifies the process, at least that's what we think it does, and it dovetails, not matches, but it dovetails the National Registry of EMTs process, so we're moving that direction with this rule change. So it starts with lining out some language there in the initial paragraph. It really doesn't change anything there. It just tried to clarify some of the information on carded courses. In our business, folks realize what that means: advanced cardiac life support, basic CPR, the carded courses that are required, and just clarifies some of the language there. It also clarifies in that paragraph how much of the new required CE number can be acquired in asynchronous methods, meaning online, articles, any kind of continuing education that doesn't involve a live instructor interacting with students. There at the top of A, you'll also see that we are now, again, reiterating that not only initial license candidates, but renewal candidates need to provide us with a valid personal address. And again, I think, as I said, that term or that phrase needs to be probably corrected every time. And then just a real quick note, not only we wanted to make sure and include in rule, and this is the first time it's referenced, that the Bureau website listing of licensed individuals is considered proof of licensure. And so this is the first time that that is referenced. So under 1B there towards the bottom of the page, where it says, or the Bureau website lists the individual as licensed. That will become more important later in this rule as well. And you can also see that when we remove someone's name from that list, they are no longer licensed, whether or not they still have a wallet card or not. And that is an important differentiation. Okay. The top of 13, renewal deadlines are the same, but we did add some verbiage just to clarify those renewal deadlines. There at the top about postmarks, etc. Because interestingly, the language was a little unclear, so we wanted to make sure about that. A new D was added to replace the downgrading. I mentioned that the surrendering of license was moved to another place. So that has been replaced with audits. We wanted to make sure that folks are aware in rule that they can be audited during the renewal process for all of the information that they are submitting. Okay, let me see, bottom of 13. What do I have? The bottom of 13 begins the list of requirements for each level. So F is licensed emergency medical dispatcher. Each level is now listed after this with all of the requirements for that specific level. Their CPR cards. It starts breaking down the hours that are needed for each subject. I'm not going to go through each one of those, I promise. We have lectured on these changes for the last 2 years all over the state in multiple places. It's been met with support most of the time. It goes through in EMT basic, intermediate on page 15. It begins paramedic at the top of 16 and goes through their renewal requirements, and then concludes towards the bottom of page 16. We did add some new information there about reattaining a license after expiration, just to clarify that it's not really late renewal. that they are expired, but now then it just clarifies how they can now reattain that licensure once they have expired through reinstatement, reentry, etc. Again, nothing has really changed. We just changed some verbiage there to remove the requirement of a refresher, seeing as how we no longer require a refresher for CEs. We also no longer require a refresher for re-entry. So we just clarified that number of hours. Now, on page 17 at N, it starts defining the Bureau Continuing Education, and just again, no huge changes, just some strike and delete to clarify some language. Under continuing education categories, those have been reformatted with the combination of a couple of categories into one, and the addition of a cardiology category, and so that's added, and it just describes each category of CE. And then it discusses forms of CE. Again, there's no huge changes through any of this. It just there's some clarifying language for strike and delete at different points, but nothing that changes anything significantly. All right, moving on down to there is nothing of significance on page 19, other than at the very bottom of 19. Again, the EMS Bureau does not require a refresher certificate for renewal, but then the majority of that paragraph continues on the top of page 20. And so it just describes now that, again, a refresher cert is not required, more now just a number of CEs. And we know, though, that schools will continue to teach refreshers, as is their choice. And this tries to explain how those hours will be applied to the new CE requirements, just broken down by hours, etc. So it's nothing earth-shattering by any stretch, but just an explanation of how that will be handled. All right. Under identification of personnel, a new letter D paragraph has been added. Many of you are familiar with the fact that we have had imposters who have forged licensure and actually have fooled entities into being able to volunteer and or even get paid to work as an EMS caregiver. And so this is now in rule that any entity that is regulated by the PRC or by the EMS Bureau by rule should be checking our list, not the wallet card. They should be checking our list to assure licensure for their caregivers, and that is a very important addition. Again, it's easy to forge our wallet card, unfortunately, or at least forge a copy of our wallet card. And the only way we can combat that at this time is by making sure that list remains online. And then it adds another bit of language. Certainly other entities utilize licensed personnel, ERs, urgent cares. We do not regulate them. We cannot require that they check, but we certainly encourage them in rule to check that licensure and make sure that those folks are licensed. Nothing under fees, there's just some clarification. No fees were changed or increased, but there's just some strike and delete language improvements. And then that takes us to the bottom of page 22. And under 4E, under commission meetings, it just clarifies that members of our licensing commission may attend licensing commission meetings by telephone or other teleconferencing technology, and that it was just placed in rule. All right. Page 23, 7B, there was just some clarification of action that the licensing commission could take after a bureau investigation to show other immediate action, including but not limited to suspension. Again, just improving language there. Then 24 has just some grammatical changes, nothing there. Page 25, a quick clarification of unprofessional conduct. There under G3C, it is clarified in rule that unprofessional conduct may occur on duty or off, and that that can be indeed cause for investigation and licensure action of an EMS caregiver, as that has been a defense before for some things. So we just wanted to make sure that that was clear. All right. The next major, nothing of substance on 26, nothing of substance on 27. There's the training and education, strike and deletes at the bottom of page 27. It looks impressive, but we've mentioned that. Occurs multiple other times there on page 28. But 28 moved down to number 4, grounds for enforcement action, under 4D1, or little 1. Failure to comply with laws or rules, including but not limited to the failure to properly educate students on the licensure process. These are enforcement actions against education entities and ICs. And so it is now in rule that someone needs to be taught how to license appropriately, because unfortunately that has been an issue. So now that is in rule. Top of 29, nothing of substance. 30, nothing of substance. 31, nothing of substance, in fact, no changes. 32, just some grammatical changes and some reordering. And 33, under B6, it just was clarified that not only must, when someone is trying to show us an equivalent criminal background check, that they state that they've had an equivalent background check, that they have to provide us proof. It seems like that's a silly addition, but folks are very in tune to rules sometimes, so we need to make sure that they know they have to provide us proof of that and not just tell us that they did. So, all right, 34. Page 34 is a significant addition, beginning with 7.27.2.17. Basically, this is new verbiage for the consequences and verbiage for coming back from revocation. That has become an issue over the last year or two, actually past 2 or 3 years, about what revocation meant. Is there a way back from revocation? Is there not a way back? And after much discussion with the Licensing Commission, this was ruled that was proposed by our Office of General Counsel, to whom we're extremely grateful for their professional and immaculate wording for this section. And it does explain there is a way back from revocation, but there is a minimum number of years and then a process for which a person must go through. And again, it's a significant addition, but very well done, very well worded, and vetted at length by the Licensing Commission for our EMS group. I know that was a long overview, but I wanted to be sure and hit those areas of change. And that concludes the overview of the licensing rule.
So, I was just going to indicate that if anyone has any comments or questions on part 2, they should come forward, and I think that was a good time to address those, since we just had a thorough summary of them. And remember to turn the mic on, please. And what's your name, sir, and who do you represent?
Mark Samuel, Battalion Chief, EMS, Rio Rancho Fire Department.
Thank you. You may proceed.
Just a question back from our department is, We see that in statute, it says EMTI for intermediate. I was wondering if there would be a change to EMT advanced.
If that concludes your question?
Yes.
No.
Okay.
And there's a little bit more of an explanation, but the short answer is no. The advanced EMT, the national scope for the advanced EMT, is not New Mexico scope for EMT intermediate. So we felt that it was more appropriate to maintain the term intermediate to differentiate it from AEMT, even though we know we use that licensing exam as proof of base level competence. We trust the schools to teach that additional scope of practice that makes them a New Mexico intermediate rather than a national AEMT. And obviously we're a little prideful. We believe New Mexico intermediates are better and more prepared and more able to assist patients, especially in our geographic vastness, than an AEMT would.
Okay, thank you.
Thank you. Any other questions or comments on part 2 of the proposed regulations? All right, let's go ahead and move forward, and as I understand, you'll be referring to Exhibit 8, which is part 6?
Yes, sir.
Okay.
Part 6 is Emergency Medical Services Advanced Directives. The main summary change, if you will, is that we're adding something called Medical Orders for Life-Sustaining Treatment form. And the MOST form has actually been in use in our state for almost 5 years, primarily in Las Cruces, Albuquerque, and some in Farmington. And we felt that it's a very effective form, and it is added to our EMS DNR form as an option. So that is primarily the reason for the changes. Starting at the top of page 1, some nomenclature changes, clarifying that we're just our name and some of the stuff there. Under scope, just of note, we added advanced practice nurses and physician assistants as caregivers, so to be included in this scope. And let's see, through the rest of page 1, nothing much until B, we added a new B to define advanced practice nurse. So that definition there does exist. Moving to page 2, one of the other changes is clarifying pardon me, this is just the part that clarifies designee, adding social worker, and other folks such as an advanced practice nurse or physician's assistant who can explain an EMS DNR and execute that DNR. And that's an important change. It used to say physician only, but now those mid-levels are now included, and that's a good change. And you'll see that advanced practice nurse and physician's assistant addition throughout the document. Also on this page, a new M is added to define the New Mexico Medical Orders for Scope of Treatment form, the MOST form, and that definition is there. A new definition for physician's assistant, and then under EMS do not resuscitate order, again some additions there. And then that last the last portion of number 1, a registered nurse may sign the EMS DNR or MOST if a verbal order for the EMS DNR or MOST has been received from a physician, advanced practice nurse, or PA. The name of that physician, advanced practice nurse, or PA must be printed beneath the signature. The reason that was there is we've had situations where a verbal order was given, but it wasn't entirely clear that an RN could sign for that physician. So that's a good addition. It makes this more available to more folks. Let's see, under 2, basically some of the same verbiage, nothing terribly exciting there. Again, just trying to make this. You'll see the term MOST added now throughout the document, just to assure that it's in rule just the same as the EMS DNR. So now to page 3 and B3 and 4. Let's see. Basically, that is just a pardon me, and just making sure my notes here, that DNR verification steps now include the most form verification steps as well. So if you see somebody, how to verify that they are the person for whom that EMS DNR or most form has been completed for. A interesting but I think important addition. It's one of those that's only one word. But at the very bottom of number 3, or page 3, pardon me, under, I guess it's a new 5 there. If there is any question about the validity of an EMS DNR or most form, or there is any indication of an attempted homicide, the term "or suicide" has been removed. This is the way the rule was initially written by Dr. Tim Fleming. Many years ago. He did not include suicide intentionally, and that is being reverted back to the original rule verbiage as a proposal. So, but it is somewhat significant, and I wanted to point that out. And let's see, then the last note I have is for page 4, where it just includes the term most form in multiple places throughout that document or that page. And that concludes the substantive changes for Part 6.
Okay. Are there any questions or comments related to Part 6 of the proposed changes to the regulations? All right, then I guess we'd be moving on to Exhibit 10, which addresses Part 8 of the proposed regulations.
Part 8 is Cardiac Arrest Targeted Response Program. The major change in this is that physician medical direction is no longer required for a civilian AED program. That is already in statute and is already enforceable. We're not requiring physician medical oversight. We just needed to get the rule up to date. And I just, that's kind of the overall main change. There's, on page 1, there's multiple cleaning up of language. I did see something on page 1, A3, the wording just, and there's lots of strike and delete, but it looks like the term military services, then other federal entities and AED programs on tribal land, the United States Department of Defense, other federal agencies, and AED programs on tribal land. It seems like it's repetitious. Or redundant, I should say. And I thought maybe that was just a grammatical thing that could be repaired. Certainly not anything that's make or break. Let's see. There's a lot of cleaning up of the statutory authority, but nothing that changes rule or the application of rule. At the bottom of page 1, there's just some changing things to non-capitalized things, so nothing that is huge change there. Page 2, the large change there is down at I, where the portion describing medical direction is removed per my earlier comments. Physician medical direction has been removed, so then J was also removed. We don't need to define physicians as they no longer appear in rule. So that's gone. And then down to N, it just clarifies that a designated trained targeted responder will be responsible for guidance or supervision for the AED program, basically designating a supervising targeted responder rather than a physician to oversee the program, which we have heard will make this much more applicable for some of our private folks out there. Page 3, you'll see that a lot of B was eliminated there. Basically, all of that strike and delete just is to make sure that folks know cardiac arrest. I've got to find all the words, but basically, there it is. Cardiac arrest programs may be initiated in any environment where members of the public are encountered. That sentence replaces all of that paragraph and all that verbiage. You just have to find the words in there through the strike and delete. But that is just greatly simplified the idea of it. And then again for location, etc. Under also all the physician verbiage was removed there throughout that page as well. And then let's see here. The next thing I have is page 4, which is mostly nomenclature and verbiage corrections. I did want to point out G, that at the bottom of the page it adds language for allowing the petition of the Bureau for a completely automatic AED. The previous rule precluded the use of a fully automatic AED. For those that might not know what that means, that simply means there are AEDs available that you can place pads on the person and the AED does everything, including the actual shocking of the patient. You don't push a button, you don't interact, you stand back. Some folks want to use that kind of AED, and if they want to use it, then they can ask us to utilize that, and it will almost assuredly be granted. The remainder of this rule, after this point, basically starting on page 5, well, actually, page 5 does simplify some of the immunity language. I apologize. And by doing so, it just refers you back to the statute. The statutory immunity language was actually revised by Dr. Barry Ramo, and he's the one that made the suggestion. And so that immunity language is in the new statute, and so it's simplified here. And then, pardon me, the rest of the, from page 5 all the way through the end of the rule has been deleted. Basically what occurred was the entire application was placed into rule, which meant we couldn't change the application or make amendments to it, or and so that has been removed from rule and will just now be an application that's available and amendable, etc. So that is the changes for the AED.
Are there any comments on part 6 of the proposed rules? Okay, then we can move on to Exhibit 12, I believe, Part 11.
Indeed. This is Part 11, Supplemental Licensing Provisions. This is the scope of practice these are the recommendations and proposals made by the Medical Direction Committee and agreed to by the Department of Health a while back. We are looking forward to getting these into rule. One of the things I wanted to point out, though, is this is one of the rules that, interestingly enough, in the very first line, we were changed from the Emergency Medical Systems Bureau to the Board. And I believe that is simply a grammatical error, but does need to be corrected. I just wanted to mention that. Otherwise, on page 1, there is an addition there. If you'll see, it says in the event of a under scope, I apologize, in the event of a public health emergency that stresses the emergency medical services system and disrupts delivery of medical services, the New Mexico Department of Health, working with the Emergency Medical Systems Bureau, may limit or expand these rules and may institute certain crisis standards of care through emergency rulemaking. Crisis standards of care is a term that is rather popular right now around the country to make sure departments of health can assist their states in times of duress by increasing or changing scopes and recommendations and standards. during major responses. So we wanted to make sure that that theory was put into our scope of practice to show that at some point it might be perfectly acceptable to transport patients in the back of pickup trucks and allow that. So we just wanted to make sure that that was in there. Other changes are primarily grammatical on page 1, so nothing of substance. Nothing really of substance on 2, just some strike and delete grammatical changes. Page 3, this was a very picky thing, but let me see, it's under the number 3 there, utilization of advanced patient monitoring. The term Swan-Ganz was decapitalized, and I know that occurs a lot in rule, but that's actually the formal name of 2 individuals, Dr. Swan and Dr. Ganz. So I didn't know if it should have been decapitalized, but again, that's a kind of a picky thing. Let's see, page 4, 2I. What was I looking at here? That may be under K. Oh yes, under the first responder scope of practice. So under K, number 2, it's not an I, that's actually a Roman numeral small 1. We added, this skill includes devices that provide non-invasive positive pressure ventilation via continuous positive airway pressure, CPAP. CPAP was never intended to be removed from the first responder level. It was there, it fell off, it's back. And it's really just clarification language. So nothing exciting there. Page 5, under basic, there's just a real quick spelling out of FiO2, but that's not the important part. Towards the bottom, under C, number little 7 there, ibuprofen PO in pediatric or adults to treat fever or pain. Ibuprofen has been added to the scope of practice for basics. And they can use that for pediatrics or adults for pain or fever. That's a large change. Going from Tylenol, or pardon me, acetaminophen only for pediatrics and fever, and now then having an additional pain medication at the basic level. That's important. Next page, page 6, didn't really have many changes. Page 7. Down to C, number 5, ibuprofen oral or IV or IM has been added to the intermediate scope of practice. Again, a substantial change and a substantial addition. Below that, that would be number 14, nitroglycerin. Nitroglycerin's use by the intermediate has been expanded through the removal of restrictive language. The term for chest pain associated with suspected acute coronary syndrome has been removed, allowing intermediates now to treat conditions such as congestive heart failure with or without pain. And that is a substantive change. So that was agreed to by the Medical Direction Committee and added. Below that, number 19, XIX, and then just above that, the old 18 was removed. Methylprednisolone is a very specific drug that was removed and replaced with the term corticosteroids for respiratory illness or allergic reaction, adding the class of corticosteroids instead of the specific medication, methylprednisolone, and just allows some more flexibility. Okay, that is it for substantive change on page 7. Nothing on page 8. The fact that, pardon me, if you have a question you'd like to ask, you can go to the microphone. So.
Donnie Roberts with EMS Region 3. And the question I've got is under hydroxycobalamin. They've got a strike through and it says corticosteroids. Is that a corticosteroid?
No.
Or is it a vitamin?
Okay, hold on. Let me see. I moved past the page. I'm sorry. Let me go back. Hold on.
And it's under XIX.
All right.
I think hydroxy, whatever it is moved down.
Oh, I see where they moved
Yeah,
it down.
it just got moved down to 20.
Okay, I see it now.
Yeah.
Okay.
And I knew that, but I couldn't remember. So, yeah. So there you go. And you're right. It is B12, by the way. So,
Thank you.
all right. So that takes us to page 10. And under paramedic, okay, under let's see, so this would be 24, XXIV on the top of page 10. NSAIDs, non-steroidal anti-inflammatory drugs as a class have been added to to the paramedic level for pediatric or adult patients with pain or fever. That's a big change. So instead of being limited to ibuprofen, as the basics and intermediates are, there are 43, at least 43 NSAIDs available, and that entire class of medication is available to paramedics for use, of course, with approval by their medical director. That is a significant change. And then, let's see, that really concludes. There's some strike through and additions, but that is all just renumbering. So there's really nothing added to the scope until you get underneath drugs allowed for monitoring. So there at number 3B, they added tranexamic acid, TXA, to the anticoagulation type blood modifying agents that paramedics may monitor. Then just down below that, you will notice that H used to be dobunamine, and it has been removed with sodium nitroprusside just moving up. The reason dobunamine was removed as a monitored drug is that vasopressors as a class are already in our scope. And so it was redundant and just missed in previous editions. The same goes for norepinephrine at L, below that. So norepi has also been removed. And then towards the bottom of page 11, that is all for the scope of practice. At the bottom of page 11, while Santa Fe Community College has been an approved program for quite some time, it was just never officially added in rule. And so that is added. There are no changes, no other changes until 15, page 15. And this is a new, under D2, this is some clarifying language. It has come up over the past year or so about who's in charge. And it's never been actually determined in rule. We've always left that up to local medical control and systems, etc. So by necessity, a paragraph has been added indicating that the EMS caregiver with the highest level of licensure during the call is the most responsible for the care the patient will receive and is designated as team leader. If there's multiple caregivers of the same licensure level, a team leader shall be designated by system guidelines. The team leader may assign other licensees to be another licensee to be the caregiver, but that team leader remains the most responsible. New verbiage, but important, and that is our proposed additions to the scope of practice supplemental provisions.
Are there any questions or comments on part 11? If you could repeat your name again for the record.
Mark Samuel, Battalion Chief, Rio Rancho Fire Department. The question came up with the team leader or the most responsible person. If a paramedic is on scene and deems that it doesn't need ALS intervention and hands it down to either basic or an intermediate, if they're required to do a patient care report with the documentation, they did transfer the patient care to the intermediate or to the basic, and now that they are the primary team leader, or how would that rule affect that?
Excellent question, Chief. Are we talking in a transport situation, or are we talking somebody saying you can handle this and leaving?
For an example, an engine and a rescue show up and we have an intermediate rescue for that day, and by chance there's a paramedic on the engine as a captain.
Right?
The captain and the engine and the rescue both respond to the call. The paramedic captain says, yes, you can take this into the hospital, and now it's down to a lower provider, but yet there was a higher provider on scene. And then the rescue would leave, and then the paramedic would go back on the engine, and then.
Right. There's probably a better answer that would be better verbalized with some time to consider. Initial reaction is that in that situation that the intermediate would become the team leader because they would become the highest person on scene or for patient care as the other person has departed. And just as with anything, as long as things go well, it would be fine. If en route that patient developed a situation that is determined someone should have recognized before they left that scene, and something bad happens as an outcome, that might not work so well. So it would probably be indeed situational specific, but I do believe the rule has enough ambiguity left in it intentionally that that is something that we know from a common sense perspective occurs, and that it would not be precluded from occurring by rule, but someone needs to be confident of their skills and their caregiver colleagues.
Thank you.
Are there any additional questions on Part 11 of the proposed changes to the regulations? Mr. Gerald.
Attention, I'll close fire department. Kind of to piggyback on his question as well, from a slightly different perspective, however, his question primarily pertained to handing off the patient care from a higher level to a lower. In regards to the situation where you have, say, a paramedic who is a battalion chief, responds on scene to an MVA, while they may be the highest level there, they are not going to be directly involved with patient care because they're in command of the entire scene.
Right?
Say an ambulance shows up with an intermediate on that box and is assuming that patient care for that entire time. The same situation, I would assume, except for the fact that in this situation, the paramedic would have never even been giving any kind of patient contact, patient care.
Right.
Would that be taken in regards for this?
I think that situation in particular, the rule allows for the designation of team leader by local protocol.
Mm-hmm.
I think that would need to be very well explained and delineated in your local protocol. Who the team leader will be. Battalion chief has control of the overall scene, is not assuming medical control necessarily or medical command. The team leader will be the highest trained person on the rescue at that time.
Okay.
That's how I would deal with that.
In that situation, would you think of the battalion chief as being an EMS caregiver for purposes of that call, or is that the distinction that we make?
In all honesty, they probably would not be an EMS caregiver. They would probably be situational control.
So that might be the distinction that's made because the text is referring to the EMS caregiver with the highest
Specifically.
level of licensure.
Right.
If they're not a caregiver, then it shouldn't be an issue.
You should exclude them.
Right. But I would make sure that that is in SOP.
Okay. Thank you.
Yes, sir. Thank you. Very, very good question, Mr. Chanel.
Hi, Charles Schroeder, EMS Program Manager. Maybe a recommendation in the language to denote the personnel mission specific what is their mission on the call? Are they assigned directly towards medical? Are they assigned specifically for fire or overall scene overview? So some sort of language where it says mission specific towards the EMS provider.
So would it be something like, just something to clarify? Would it be something to clarify what we're referring to when we say EMS caregiver?
Yes.
So maybe instead of mission specific, to sort of spell that out more, to say something to specify that we're referring to an individual who is actually performing medical services during the course of a call.
Correct.
Okay.
Thank you.
I think we can wordsmith something.
Right, I agree. We'll be glad to help.
Are there any other comments related to Part 11 of the proposed regulations? Okay, then we can move on to Exhibit 14, Part 13.
Part 13 is the stroke certification of stroke center rule. This is the shortest rule change. This is also one, however, where we were changed to board. There at the very first line, number 13.1. And I do, again, just point that out for a change. Let's see, under scope, this was a fairly significant change. Doesn't change much for many folks other than the Bureau and the hospitals. But initially, interestingly enough, the statute was written very specifically to include only the Joint Commission as an accrediting agency. But there are other accrediting agencies. And so the statute was changed, and so the rule has been changed to recognize other nationally recognized accrediting bodies that accredit stroke centers. So that phrase was added to scope. Then we go down to definitions, and under B, accrediting body is defined there for you. And that's interesting. I just noticed this. Under Bureau, they changed EMS Bureau to Injury Prevention and Emergency Medical Systems Bureau, which we are not. And that appears to be an addition. So we would recommend that it goes back to the original language. So I did not notice that till just then. So I apologize. Let's see.
If I could ask a question about that,
Mhm.
shouldn't it be board then? Isn't that what you're doing throughout here?
No, board is incorrect language. We are a bureau.
Okay.
Yeah, that change to board occurred on 2 of the rules, and it needs to be changed back to bureau.
Okay.
So, interestingly enough, but things happen, and we absolutely understand.
So your recommendation is that
Under the
D,
term
it
bureau,
should just remain the same without the red line.
right, there
language.
should be no strike and delete
Okay.
or addition there. Just means the EMS Bureau of the Epidemiology and Response Division.
Thank you.
Let's see. And let's see any other nationally recognized accrediting body. The Joint Commission there at the bottom, it gets kind of jumbled, but there's an F that has been deleted. It used to define Joint Commission. That has been removed simply because they are an accrediting body, which is defined elsewhere. Page 2, this is also an interesting thing I just found. Right at the very top, the new J, stroke, is a term that broadly describes the death of central nervous system cells and tissues attributed to an insufficient supply of blood. That word tissues and attributed has been combined into one word, and again, it's just sort of a bizarre, I think just a grammatical error that just needs to revert to the regular or the formal wording there. Okay, and then the last thing of substance is page 2 under stroke system development down to C. It does state that working in coordination with all local and regional EMS authorities, a stroke protocol will be developed. It's the first time, interestingly, that the Bureau has been charged with developing protocol. We've always developed scope of practice. We've always maintained treatment guidelines, but those are not in rule. This is the first time that rule has required the Bureau to develop stroke protocol, or any kind of protocol. So we do actually have a protocol that we've been working with, because this is statutory. It's been in statute for 2 years. And we are working to try to develop a stroke protocol that applies to the whole state, which is not always easy. So that is in process, but it is now also in rule, as it should be. And that is the last of the substantive change.
Are there any comments or questions on Part 13 of the proposed changes to the rules? I may be missing something, but I'm still not clear on this Bureau board question, because, for example, on the top of Part 13,
Yes, sir.
subsection 1, it changes Bureau to board.
That is an incorrect change.
Okay.
Yeah.
And so throughout these rules, that's incorrect.
It only occurred twice.
Okay.
It occurred on Part 11 and Part 13.
Okay.
It did not occur on Part 2, Part 6, or Part 8.
Okay. Thank you. I think I've got it now. Mr. Schroeder?
Yes, sir, just one other mix-up of acronym, or Epidemiology and Response Division in Part 13 is parenthetical EDR when it should be ERD.
Oh, very good catch.
So where specifically is that, Mr.
Part
Schroeder?
1, 13.1.
13.1.
Yep. First line, actually right before board.
Oh, I see.
Yeah.
Okay. So it should be ERD.
Yes, sir.
Correct. And if I may, on Part 11, supplemental licensing provision, on 11.1, there's the same issue.
Yes, sir. You caught that one. I focused on board and missed the EDR. Yeah.
Thank you.
Thank you, Charlie.
Thank you. All right. Any other comments or questions from the public? All right. At this point, we need to address getting the exhibits in the exhibit binder into the record, and Mr. Woodward will read those into the record.
All right. So we have a number of exhibits to enter. The first exhibit is a copy of the notice of public hearing that was made available to the public. You'll notice that this notice is a little lengthier than past notices that we've had for public hearings, and this is due in part to a recent change in the State Rules Act regarding what to include, and in fact there have been some changes as far as how you disseminate these notices. So this is the notice of this rule hearing. It describes the substance of the rules and identifies the date and time of the hearing and so forth. This was made available on the EMS Bureau's website, as noted on the notice towards the bottom there. It was also published in a newspaper, so if you turn to Exhibit 2, our second exhibit, this is an affidavit of publication from the New Mexico Commission of Public Records, and this attests that this notice was published in the New Mexico Register as required for all such rule notices under the State Rules Act. And I believe after that affidavit, we've got a copy of the portion of the New Mexico Register where this notice was published. At Exhibit 3, we have the affidavit of publication from the Albuquerque Journal. One of the things that we're required to do for these notices under the Department of Health Act is to publish the notice 30 days in advance of the hearing, and in fact that is now a requirement under the State Rules Act with respect to the New Mexico Register as well. And so you'll see that it was published in the New Mexico more than 30 days in advance of the hearing, also published in the Albuquerque Journal more than 30 days in advance of the hearing. On the second page of Exhibit 3, you'll see it's you would need a microscope to read this text, but this is the cutout of, and we may have actually shrunk this for purposes of the photocopy. This is the cutout of the actual print of the actual newspaper section that included the notice that was affixed originally to the affidavit of publication, so we've included that there. At Exhibit 4, we have the appointment letter appointing Mr. Erickson as the hearing officer in this matter. Exhibits 5 and 6 consist of Title 7, Chapter 27, Part 2, so this is the licensing rule. We included, as we did for the handouts today, we included both what I call the clean copy at Exhibit 5, which just shows all of the changes just as they would appear if this was published. And then at Exhibit 6, we've included the so-called tracked changes version that shows the line item strikes of everything that was deleted and all the replaced items are underlined and so forth. At Exhibit 7 and 8, at 7 we have the clean version of 727.6, and at Exhibit 8 we have 727.6, the strike-through version. At Exhibit 9 we have the clean copy of 727.8, the cardiac arrest targeted response program. And then again here at Exhibit 10 we have the strike-through version of 727.8. At Exhibit 11 we have the clean version of 727.11. And I just noticed a minor problem there at the top of the first page on Exhibit 11, that at the second line, that 27 has been sort of moved over. I think that should be joined there with chapter. Minor formatting error there. At Exhibit 12, we have the strike-through version of 727.11 and the same issue with that 27. Again, I'll have to correct that. And at Exhibit 13, we have the clean version of the Stroke Center's Rule 727.13, and then once again at 14, we have the strike-through version of that same rule. Apart from these, the 14, let's see, did we cover all 14 here? Did I cover all of them? I think that I did, okay.
Yes, you did.
So apart from these 14 exhibits, I suppose we should also offer into evidence the sign-in sheet from the hearing. So I believe everyone here has signed in, so we'll offer this sign-in sheet as Exhibit 15.
Okay.
And Charlie, do you know whether we received any written comments in response to the notice of rulemaking?
Did Mr. or Dr. Jennison, did he provide anything written?
Nothing relating to changes of the rule.
Okay.
Okay, then I've not received anything.
Okay, so hearing that, it sounds like we don't have any written comments to include as exhibits. We can provide you a copy of the recording of the hearing after today's proceeding, and if you'd like, we could have that identified as an exhibit as well.
All right. The 15 exhibits that we have here today will be admitted into the record as exhibits for this hearing, as will the recording of the hearing today, and that will be Exhibit 16. My understanding from Mr. Schroeder, if that wasn't plain on the record, is that there were no written comments, and so there are no additional written comments that will be part of the record. Basically, from here, my obligation is to issue what's called a report and recommendation to Secretary Gallagher. It's a written document that summarizes the proceedings today and makes a recommendation to her as to what I think should be done with respect to the proposed changes to the rules. My goal will be to get that out in the next couple of weeks. I think I have a 30-day deadline, if I recall correctly, but it seems like every set of rules has a different deadline, but my hunch.
Actually, it may be that you don't have a deadline on this. I think 30 days, that might be a licensing rule.
I think you're right. But anyway, my intention will be to try to get it done in the next couple of weeks. The Department of Health and I would like to thank the people who spoke today and participated in the hearing. The audience is reminded that the new rules will become effective 30 days after they are filed with the State Department of Health, and I hereby adjourn this proceeding. Thank you. We can go off the record.